03. I see the numbers have started to slow down. We can get started with some housekeeping. Good afternoon, everyone. Welcome to the Greater Illinois chapter of HIMSS virtual event. We're live and really excited to be here with you today. This webinar is titled, as you can see, Better Together, Closing the Gap on Telehealth, or excuse me, on Health, Freudian slip. My name is Maria Phillips. I am from RSM. I am a data privacy and security attorney. I currently serve in the healthcare pillar of the CEO Action for Racial Equity Fellowship, specifically on the telehealth team. So that's where that came from. I'd like to inform you of a few housekeeping items before we get started. If at any time you have a question, please hover your mouse at the bottom of the screen towards the middle, and then you'll find the questions box. Feel free to engage during the webinar. We like to see questions in real time. If we don't get to them, we'll absolutely get to them at the end. We will have some time reserved. Type your question in the box and we'll answer as many as we can live. And if not, we'll get back to you afterwards. The question will be answered via email if we don't get it done in the time allotted. Upon exiting the webinar, you will be presented with the evaluation survey. We appreciate all feedback, but if in particular you're requesting continuing education credit, you are required to complete an evaluation. So after you submit that, you will get your certificate in email by the end of the week. So make sure you do fill that out if you're looking for CPE. Again, welcome to the event. We thank you for taking the time out of your busy day to participate in this really fun and dynamic educational event. We'd like to thank all our sponsors for their support, because without them, these events would not be possible. So I'm going to go quickly through our sponsors: Comcast Business, LK, Fortinet, Secure IT, Konica, Zebra, Assimile, Pure Storage, Trinisys, Accenture. Thank you to all of you. Connect with us on social media. Search for GIC HIMSS on LinkedIn and GIC HIMSS on Twitter and Facebook. We'd love for you to stay informed and join the conversation. And certainly if you want to tag us in any feedback, we love that as well. So with that said, we'll get started with today's program. I'd love to introduce my esteemed panel of speakers. We'll start with Chad KONCHAK. He's the Assistant Vice President of Clinical Analytics at Northshore University HealthSystem, a 6th hospital integrated healthcare delivery system in the northern Chicagoland area. In his role, Chad oversees the team responsible for Northshore's clinical and operational reporting, analysis, and predictive modeling, which focuses on leveraging and delivering data that improves the quality of healthcare, patient and physician experience, and efficiency of the healthcare system. Chad also serves on Northshore's Health Equity Impact Team, leading how technology and analytics can support Northshore's equity goals. Next, we have Yadira Montoya, MSPH. She's a research scientist at NORC at the University of Chicago, where she leads and supports applied research on topics of Latino cognitive health, aging, and immigration. She has over 14 years of experience in community and public health practice with a focus on medical and social science, health education, and community engagement. Yadira was selected for the 2019 cohort of the Culture of Health Leaders, a national leadership program supported by the Robert Wood Johnson Foundation, to create collaborative solutions that address health inequities and move communities toward the culture of health. She is also a founding member of La Brocha, an art program that offers art programming to Latinx older adults, 60 plus, individuals living with dementia, and their caregivers in various Chicago neighborhoods. Next, but certainly not least, we have KRISHNA RAMACHANDRAN, currently serving as the Divisional Senior Vice President, Healthcare Delivery at Blue Cross and Blue Shield of Illinois. In this role, he's responsible for contracting and collaborating with providers in Illinois to improve health outcomes, reduce costs, and enhance the quality of care for Blue Cross's 8+ million members by aligning incentives and using actionable analytics and data exchange capabilities. Past experiences include serving as Chief Administration Office for DuPage Medical Group, now Dooley, and as Director of Technical Services for Epic. Thank you all for being here. Welcome. We're super excited to have you. And with that, let's get into the meat of it. I'm going to stop sharing my screen so everyone can actually see the panelists and not our faces that are fake. So with that, let's just set the ground here with what does equity mean? When we talk about equity, there are a lot of definitions, and I think most frequently it gets mixed up with equality. So as a foundation for the discussion, I'd like everyone who is attending to understand that equality means each individual or group of people is given the same resources or opportunities, whereas equity recognizes that each person has a different circumstance and allocates the exact resources and opportunities necessary or needed to reach an equal outcome. So with that, I want to start with really asking the panel to describe what is equity to them, how you're addressing it in your daily work, and really, if you want to talk about foundational elements of equity, let's start with, how about Yavita?
Great. Thank you for the invitation to be part of this panel, and I'm looking forward to our conversation. Just wanted to say that before I get started. Such a good question, and thank you for level setting. I think for me, my language around health equity is constantly evolving. I believe that health is a basic human right, and as a public health professional, I also believe that all of the in social determinants of health, and that more than anything, that we should be looking to find opportunities so that we could all thrive, not just survive. I think that when we talk about health equity, it's really important for me that we all have equal opportunities, and that is to thrive, that improves our quality of life, not just meeting basic needs. That being said, I also look at health equity through a lens of, again, the public health that I mentioned, social justice that comes from my background, being an immigrant, Mexican immigrant raised in the southwest side of Chicago, and then the aging piece. So looking at things from an intergenerational lens. So how do we look at health equity opportunities, health risk, and opportunities from like babies to older adults? So I'll leave it at that for now.
Thank you. KRISHNA, same question.
Yeah, thank you. No, thanks for having me and us. Yeah, I'd say, I think from a Blue Cross perspective, we have 8 million members. We are in every zip code in this state, and we have such a wide reach. We have 100,000 providers, 2,000 facilities. So our providers, our members come in all shapes and sizes and all ethnicity, all geographies. And so how do we be a player that is providing accessible, affordable care to them has always been a part of our 80-year mission. From a health equity perspective, it's been a topic close to us for a number of years. Part of the affordable accessible care is how do we reach our members that need care. So we've done that in a number of ways. We've done that by actually actively going from just the commercial line of business into Medicaid, into Medicare Advantage, into retail. We probably lost billions along the way, but this was so close to our mission. We wanted to make sure that people had access to affordable care, and we've stayed in it for a number of years. We've done it by partnering with community partners across the state. We have community partners, 100, 150 of them every year that we support across their efforts as well in equity and providing accessible care across a number of pillars: food, health, access to vaccine, education. And we've also done it by actually being a presence in the communities. We have a Blue Door Neighborhood Center in Pullman that we opened in 2019, in Lawndale, and in Morgan Park. So this is how we can be a part of the communities that we are trying to support as well. So those are some ways we think about equity and figure out ways by which we can use our breadth and depth of expertise to make a lasting impact in the communities we are part of.
Thank you. Now let's pivot from payer to provider. Chad, tell us how you're addressing equity in your daily work.
No, I think, first of all, thank you, everybody. I feel really honored to be here with the really great partners here to talk about this important topic. Yeah, I mean, very well said early on. To kind of add a little bit from the payer perspective is important, and the provider perspective and the community perspective. I love that we have that representation here. Working in a large healthcare delivery system, right? At the end of the day, our mission is to preserve and improve human life, and to be the most trusted community partner. So equity is core to our mission. I think it's important to distinguish that definition too, because we see differences in populations with everything we do, right? And just because there's a difference between one group and another doesn't necessarily mean there's equity, right? Or an opportunity or an issue with inequity. For instance, you might have an older population versus a younger population who's more at risk to be hospitalized. It's important to understand that, but we can't make people younger. We're not that good yet, right? However, when we think about equity, I think it's really important to understand that there's a foundation of something unjust that's happening, but I think equally important, it's mutable, right? We can do something about it, right? If we think about the way we deliver care in a different way to address a population that is experiencing inequity, then we can actually fix some of these issues, right? So the definition that we use when we think of equity is the assurance of conditions for optimal health for all people. That might mean, to your earlier point, Maria, that maybe the care we're delivering is not equal. Maybe we're spending more time on a more vulnerable population. And if we think about equity, maybe we should. And I think it's really important for us to first, the way we are addressing this is first measure, right? Using data and analytics, which is what I oversee, to understand where there are opportunities. Because the reality is some areas we don't have as much inequity as others. In some areas we have really big problems. In some other areas we have really foundational problems like access to care. We, for instance, see that, our more vulnerable populations have less access to primary care, and they're using the emergency department, which of course is very expensive, and it's addressing the problem really late too. I think it's really important to first measure where our opportunities are, and then focus on where are those elements of the biggest priority and foundational opportunity for us to really think about our population. So we've often been saying we need a lens of equity into how we deliver our care.
Thank you, Chad. I think that's a really great transition into my next question, which is why now, right? Equity seems to be kind of the soup du jour, but we know that inequities have been in existence for as long as this country has been an entity. So why now? And what are the foundational elements of equity? We hear a lot about it, but when we kind of unpack it, where do we start? Yadira, I will just continue my circle of starting with you.
Sure, happy to tackle this question. You're right that it seems like health equity is the topic of the trending topic. And I often really dislike hearing when we talk about the pandemic, like illuminating some of the health inequalities. And the reason I say that is because those of us who have been working on this in this field, those of us who have lived experiences, have live in families and communities that are really disproportionately impacted by health equities, this isn't new. And so to answer so I want to mention that from the beginning. I think health equity for institutions, I think that there's a couple of things that I want to mention, and that it's, not embracing communities. And this comes in research too. So these, we're going to get to talk about technology, but health research grapples with this as well, that community voice, community input is not a means to an end. It's not like checking a list, or it's not improving like a reputation or just for a grant application, but it is in fact the work that you do, how you do it, the people that you hire to do it, and ultimately asking questions. Am I creating harm? Am I supporting communities? In what ways am I doing it? And I think that that's like the very first step in terms of institutions figuring out how do we tackle health equities, but also at an individual level. So it was really important for me to talk not only about my professional experiences as a researcher, but also as a member of my community. How am I contributing to my community, whether that's geographical, like I mentioned, the southwest side of Chicago? How am I contributing to the community that I identify, Latino older adult? And so I think that those are the types of questions and reflections that we must do as individuals and as institutions.
Thank you. Thank you very much for that answer. I think that's really getting to the crux of it in a very eloquent and poignant way. KRISHNA, Chad, for the two of you, what are the foundational elements that you two are using to build your health equity initiatives?
Yeah, I can take a stab, and obviously Chad certainly, jump on there. I think I probably will want to build on what Chad said earlier on. I think part of, sort of eliminating healthcare disparities is knowing where the disparities are. And so the data measurement is a sort of a key foundation building block for almost any problem solving exercise. But as is the same for health equity. As we've noted before, this is not a new problem, right? We've had inequities for a long time. The Red Line project, which sort of maps the life expectancy along the red line. I mean, this is depressing statistics in the same city, many of us call home. Those have been around for decades. These things don't happen overnight. I must say, I'm glad to see sort of the pandemic and the racial justice movement sort of shine a light on this. And so I'm glad, of course, to have more partners that are looking at this and willing to sort of lock arms to do something about it, which I think is always, the silver lining in things like the pandemic. So that's been good. For us, I'd say, foundationally, I think it's data to understand disparities, trying to slice and dice what data we have, what data do we have to collect, whether it's through partnerships with our providers, whether it's through partnerships with other entities that collect them. And so these are elements like, even getting basic things like race and ethnicity and language. And those are, collectively, we have lots of holes in the data we have as a payer and as providers. And so trying to bridge that data divide is, I think, step one for me. And then we've spent some time on just once we do get data, whether in-house, collected in partnership with our provider partners, or in imputing based on other sources, how do we sort of understand the disparities better? And so part of where we started was just looking at our own sort of national quality measures, that we have these HEDIS measures that are done by national quality organizations, and say, what is the disparity between regions, between zip codes, between races, and how do we sort of understand where the gaps are? And then how do we then, partner with providers and community organizations to bridge the gaps, because we just cannot solve them by ourselves, and we really need, strong partnerships to help sort of solve for that. So I'd say building blocks for me is data, understand the gaps, having a measurement framework, having some interventions you can think about, and having good sort of community partners that you can actually, join forces with in order to tackle the problem, because these are complicated, multi-layered issues that we collectively face as a nation. Chad, how would you add that?
Yeah, no, I mean, I think really well said. I mean, I think we've been admiring this problem for a long time, right? So like data and analyses isn't really so much of the gap. I think it's the willingness to take action and the culture. If I look at our own organization, we've highlighted some of these opportunities for a long time, and there just hasn't been, I think, that impetus to really hold ourselves accountable to it, and payers too, to hold us accountable to it, which is also happening from that end. So obviously, over the events that happened last summer, to kind of put it with a very broad brush, it started the conversation from a very high senior executive level to the point where we've actually identified very specific measures on our corporate scorecard that we're holding ourselves accountable to. And that's important, right? I mean, it's actually saying that it's not just enough to identify where these opportunities are. We need to improve upon them. And if we don't do that, we're not meeting our goals, right? So to me, that was a pivotal change in the whole conversation, because from that, it now spins up what we're normally good at in healthcare institutions, which is, improvement, right? We see that we have high readmission rates. We create teams to figure out what's going on. We have small tests of change to deploy activity to make those things better. And now when we change the frame of reference to say, look, it's not enough to improve our readmissions overall, we also want to make sure that, for lack of a better term, like more vulnerable populations are not being left behind, that they're improving, or actually we're closing that gap. Hold ourselves accountable to that explicitly. And then the other foundational element to do that is we need to be more engaged with the populations that we serve. We've seen incredible inequity just with how we communicate, or who's communicating back with us, and the ways in which we communicate through it, advanced technology or otherwise. So building kind of a better engagement apparatus, for lack of a better term, with our entire community that we serve, which is boots on the ground. It's building trust and overcoming, issues of trust that we've had over the history of healthcare in certain vulnerable populations, and making sure that we're partnering with the right communities to really address these things and also show that we are serious about it and making and taking action. But it all, like, if I were to put it in order, right, it's measuring it, identifying our opportunities, making it real for us, holding ourselves accountable, and then sharing that with our communities and making people know that we're accountable for this too, and getting that engagement and building those systems of trust and community as not just the health system, but with the payers as well.
Thank you. And I think the really big thing for me, what I hear, my life has been completely focused on equity this past year. While this was a peripheral part of my career, it was not my full-time job. And I think the first thing that my team and I identified that was an issue for us in the policy work that we've been trying to do is that lack of data, right? The disaggregation of data in CMS and really HHS collection methods was a huge problem, because it was part of the first discussion that we had when we went on the Hill, and we made an argument for why telehealth can and will address disparities if certain measures are taken. And the big thing was, okay, well, show us the data. And we're like, guys, but you weren't collecting it, right? You didn't have it because you weren't disaggregating. You were not, and if you were collecting, you certainly weren't publishing by race, right? And so this for me is, I think, one of the biggest points of contention when we hear on the Hill about technology solutions and really equity discussion is, what does the data tell us? And that's there's anecdotal data from industry and private entities, and then there's Medicare data, right? As the largest insurer in the United States. So I heard all of you talk about it. I know, Yavita, that's your life as a researcher, is data. KRISHNA, I'm sure that you're held accountable for a lot of results when you don't have data backing you up. And Chad, like you said, without the data, you are really not able to target what community needs what and how. So maybe you all can tell me a little bit about, what are you collecting? How are you collecting it? And then what are you doing with it, right? Like, what's the next step once you look at it and start analyzing it? And then maybe you can share some of the trends that you've been seeing as inequities emerge. And I realize, Chad, you'll have more clinical data and whatnot, but I think for me, that's really interesting. So really, anyone can start here. I don't want to just be the finger pointer. I love that you all are super engaged in discussion. So free for all to start. I mean, I will point.
Yeah, you want to go?
Well, I was going to take us slightly, that's why I paused, but being a researcher, I am a big data nerd. I mean, academic journals and, Pew Research Center newsletter articles, I read them, as many of you probably do, to stay on top of the kind of trends in our industry. But I think for me, I have to push back a little bit. And when we talk about data, and I agree that we could be doing better in collecting data around race and having standards and uniformity about the types of data that we collect. But I can't help but think about there's a really good guide by the Chicago Beyond. It's like a 25-page, if you're not familiar, if you're in Chicago, I think it has application beyond the city, but it talks about why am I always being researched. And as a researcher, it's really important to me, because one of the premises of that book is like, okay, we research communities and we say, like, there's no data, let's go and collect this information. But what we really have is that, we have researchers doing or in this case, organizations collecting some type of data that that is either mandated by your government or by like a funding agency, but they're not necessarily driven by community needs. And so there's a mismatch of what data we have and what data we need to actually improve the lives of communities and individuals. And so I know I took us in a slightly different direction, but I think it's a really important thing to talk about. Like when we're talking about data, like who is coming up with the data that, like these questions that we need, the type of data that we need, who's designing research surveys and like the research questions. And then, you know, what is the value generated from collecting all of this information from individuals? And then I think it's really important what Chad mentioned, and hopefully we can get back to it, accountability. So I know your question was specific about data, but I think that we have to talk about kind of what happens before that data is collected and what's throughout and then after that's collected, because just simply talking about numbers and data sets paints an incomplete picture. And if the goal is to talk about health equity, then, you know, we have to talk about all of the encompassing issues that that we've been mentioning so far.
Great point. Great point.
Yeah, I mean, I think you're hitting on a really important point, and would have been a good response after I gave my like standard, well, this is the data we're collecting. You'd be like, oh, what about this? And because I think it's really important, right? I mean, we collect a ton of clinical data. We have, you know, a lot of that information, and we're using that, right, to do the care that we did and evaluate quality. I think a challenge for us was, well, what does it mean to be equitable? Like when we think about a lens of equity introduced into a measurement, right? Let's just say, for example, we're looking at breast cancer screening rates, for which we see a lot of inequity. Like, well, what does it mean? Like, are we just looking at people who, you know, we've documented as, Black African American versus white? What about gender? What about sexual orientation? And what about income levels? I mean, this can get really complicated really, really quickly. And the way we kind of approached it was, look, you know, we're not gonna have all the data we know about every single person. So, but we need to start somewhere. We did a lot of analysis on what we capture about people in terms of race and ethnicity, and it's not perfect, but it does show a signal. So it allows us to get moving and get started and get the conversation going. We also bring in a bunch of external data around the census. And so we know the communities our patients live in, and can look at it that way. And begin to look at things from the lens of, okay, are we seeing inequity for minority populations and for people in lower socioeconomic communities? I mean, that is very wrought with problems, but you have to start somewhere. And the reality is there's a signal that we see with our measures, and it gets this conversation starting. I think the important point you're highlighting here is that, you know, it could be that there's such a foundational inequity with regards to the care that we're delivering and the populations we're serving and the trust patients even give and how they respond to us when we ask them what their race ethnicity is. So we're even biased coming out of the gate, and we need to even back up and look at how we collect and communicate with everybody so that we can get the best data possible. But again, like, you know, perfect is the enemy of good with some of this. You're never going to have perfect information on anybody. And we do need to start somewhere. And even with imperfect data, we have 20% of our entire population is listed as other for race and ethnicity, right? By far from being perfect, but we are seeing really significant signals in certain areas of opportunity. Like I said, breast cancer screening, that to ignore that and wait for perfect data would not be doing our communities a good service.
I think that brings up something that I remember from the prep call, that I think you mentioned that of the 30% minority population that you serve, you have, I think you mentioned a 2% rate of feedback. Was that, am I remembering correctly?
Yeah, so it's another great example of also where you could use different data sets to kind of triangulate and say, look, it may not be exactly those numbers, but there's a gap here and there's a problem, right? So we're required by CMS, you know, Medicare, Medicaid, to send surveys out to patients after they're discharged from the hospital. And then these, you know, patients respond to the surveys, and there's a lot of kind of reimbursement, financial implications for how we perform on patients' perceived care. So this is government mandated things. What we found was that overwhelmingly, the responses we get back are very white, about 95%, at least with the documentation we have, versus the patients that we serve when we look at it. So even when we compare our own data, right, to each other and say, look, we know our data is not perfect, but 95% of the surveys we're getting back, our data says they're, you know, Caucasian, and the patients we serve is only like 70%. Like, there's a huge problem there, right? Just with the basics of communication, getting feedback, and even getting good signal of this metric of patient satisfaction, that there's a ton of evidence of how that's connected to quality outcomes. So again, like, when you see that, we have to do something about that, even if we also need to do something about collecting better data just from a race ethnicity.
So how do you address this, right? Like, I hear the don't let the perfect be the enemy of the good, right? I hear that. But as a perfectionist, that's hard for me to stomach, right? Like, I am always striving for better. I'm always striving to learn from how we could have made it better. Perfectionism is an unattainable goal, but growth isn't, right? So how do we learn? If we're having such low engagement, how do we get better, right? Like, what is the problem? And I think I heard a lot of themes here. Trust is certainly a foundational element. And, you know, I think during the prep calls, we talked a lot about trust and why there is distrust. So maybe one of you can address maybe the trust issue and how we can get more engagement to have meaningful interactions with the communities that we are trying to serve.
I remember our prep conversation, and something that came to mind when I heard those response rates was that early on in my career, I was a case manager for a small nonprofit, and we were working on medical debt. And so one of the questions to me comes, you know, sometimes as a researcher or as an individual in this in organizations, we're like, this is the question that we want to answer. This is kind of the problem. But we need to, when I thought about it, like, how many of those individuals are getting bills for medical, you know, like for some of their healthcare services, and they're not even opening those envelopes. Or I think the other piece is, what was the, you know, thinking about how just local and national data on how individuals of color are treated differently in healthcare settings. So then again, it's like, what is the motivation for someone to complete a response, a survey like that? Because it's like, well, I was treated badly, I received this in the mail, I think it's a bill, I'm not going to open it. Or if I do, like, I just don't want to get into that. And so maybe bringing it a little bit home, I work for a large, one of my projects is a nationally representative sample of older adults. And we're always talking about the low Latino response rates. And so I think the default is like, okay, let's look at what we can do at this moment, at this time, to tackle this response rate. But for me, it's like, actually, let's go back and look at the last 15 years of the study. How have we engaged the community? How have we, how much effort and energy have we put into materials that we sent to them? When we send field interviewers to interview them, are they bilingual, bicultural? Do the respondents find them relatable? As well as other things. And so to me, I keep bringing us to the bigger picture, but I think it's important to contextualize, because sometimes we're so focused. And again, being in research, it's like the best advice that I ever received when I was doing a lot of research recruitment is like, no one cares about your research as much as you do. And so it's, you meet people where they're at, you build trust, you collaborate. And it's the best advice, because that's the mindset that I go into. Okay, what are people dealing with, and where does this fit in, and can it fit in to their lives?
KRISHNA, I know we've been kind of monopolizing here the conversation, but I heard a lot in our prep call about the VBC program, or value-based care program, that you all have implemented as a health equity goal. And I heard all of the themes that we've been talking about, collection, disaggregation of data, adjusting delivery, adjusting to what we are hearing, what we're seeing, engaging the provider. So maybe you can tell us a little bit more about the health equity incentive program and the VBC program and whatnot that can tell us about how you're addressing some of the things that you've seen and how you've pivoted.
Oh, thank you. A good conversation. I think it's interesting that you as you think about data, we have too much of it and then too little of it, right? So we're like sort of depending on who you speak to, we're always straddling these tensions, right? And the answer is they're both right. Like, that's our challenge. So, obviously, even the data we have, to Yadira's point, it's not always collected thoughtfully. There's obviously a data collection opportunity, and then there's once we have the data, what do we do with it? To Chad's point, what are the signals we can get from it? And then, of course, there are just holes in the data which we have to sort of impute, because even to Chad's point, we haven't matured in data collection of some aspects, right? Like, and some we've really dramatically matured. And so in my word, the part that we've matured a lot is just claims data. It's been part of the oldest form of data that's existed in healthcare. People want to get paid, and so for the last 100 years we have claims data. And so certainly opportunity to sort of get meaningful insights from it is sort of step one. And then step two is how do we sort of supplement it, whether it's through clinical data from partners like Chad, whether it's through research data from partners like our community organizations and folks like Yadira, or whether it's just incenting for new different kinds of data as well, right? So there's a sort of a third set there. But I think as a payer, we have two, you heard me in my intro comments, we have a community responsibility. We are here for 80 years. We are in every zip code. And so there's a deep sort of a, with a name like Blue Cross Blue Shield of Illinois, like we're not going anywhere. Like we are here. And how do we sort of continue to care for our fellow citizens and non-citizens is an important piece for us. And so as a payer, I'd say two big things we can do is how do we use our, sort of $30 billion of healthcare spend in order to change behavior, right? How can I use the power of the claim payment in order to shine a light on opportunities and then figure out how I can incent behavior change across the board, whether it's members, whether it's providers, whether it's community organizations, to change and close these gaps. And so I'd say that's our opportunity and our challenge as well. And so one of the things we've naturally done is just using the power of incentives to change behavior. So we've done that for a number of years, and then we've pivoted to sort of the equity conversations as well for a number of years. And so two programs I wanted to sort of highlight for you all. One is just in collecting. So we've had the accountable care organization, ValueBased Care program for about 10 years or so. And the last maybe 5 years, we added incentives for our provider partners. And this covers a few million members, includes some of our major health system partners in the state. And so we've incented for behavior. Is there some sort of data collection, but there's also sort of a education and disparity awareness training for physicians. But the more important part is just how do we make sure that our provider partners are collecting the data, and how can I sort of throw parts of dollars and incentives to incent that behavior change, and how can that be sort of operationalized, and how can that become much like what Chad is saying, how can this be part of an accountable corporate sort of this, we look at it because this is part of who we are, and we need more sort of organizations like Northshore doing that. So we've done that in just sort of incenting for behaviors where we incent for data collection, but also in looking at the data and figuring out sort of action plans for bridging disparities. So that's one way. And then the second thing we did, particularly in the height of the pandemic, was really this sort of health equity hospital quality program. So we piloted a program with about a dozen health systems that are in areas where we've seen high COVID transmission, high disparities, particularly in the Latinx population and African American populations, organizations that are also teaching organizations. So we want to make sure that the health equity focus was not only on disparate populations, but also on places where there may be opportunities to have a healthcare workforce that represents the communities they serve as well. And so our incentive program, again, incentivizes for outcome improvement really related to comorbid conditions that were most impacted in COVID, so diabetes, asthma, hypertension, and COVID itself, and then in pockets and populations, so particularly Latinx communities and African American communities. And so the idea is, how do they collect the data? How do they stratify these measures? And how do you see the disparities? And how do they create an action plan? And here's where we are literally putting our money where our mouth is, right? How do we partner with our provider partners to look at it and then bridge the sort of divide there. And part of the incentive program was also on making sure that physicians and providers that are underrepresented in medicine, that there is sort of a pipeline that is being built as well, and making sure that our providers have physicians and caregivers that reflect their members and their patients. And so one portion of the incentive focuses on that. And then the other portion of the incentive focuses on telehealth measurement. So if we saw from the pandemic, talk about incentive alignment bright spots, right? We saw that when people paid for it, we had a sort of 1,000% increase in telehealth. And how do we have that stay, and how do we have that available to people that may not have internet, may not have phones? And so I think there's an opportunity for us to sort of bridge that divide also there. But knowing telehealth as a way we can create access, we want to sort of incent that behavior as well. So anyways, long way of saying using the power of our dollar, the power of our medical spend in order to influence areas in partnership with our providers has been a big focus for us last year particularly, but also a number of years prior.
Thank you. And that's a really fantastic segue into kind of the last point that we wanted to cover here, which is the technology angle. KRISHNA, you did a really great job of kind of hitting really the heavy hitters here about talking about all of these social determinants of health issues that we encounter. Obviously, the digital divide has been branded as a super social determinant of health. So when we talk about technology, it's impossible to really address this in a vacuum. We have to think about all of the ways that the community, the trust, all of the coverage, right, influence how technology is utilized. And I think we talk about kind of the three big pieces of, access, devices, right, and the knowledge and skills or digital literacy or technology literacy. So when we talk about, I think telehealth is a really fantastic example. Now that you've seen an 1,000% increase because it's now covered, and it's covered because during the public health emergency, there were all these waivers issued, which have made it possible, right? Not just for private payers like Blue Cross, but also Medicare, right? The government is also paying for telehealth services. How do we keep this upward trajectory going? And as a subpart is, how do we also make sure that the technology is implemented in a meaningful way, in a culturally competent way, so that we don't create a larger gap? And that's kind of really where this whole program started, right? Does technology help or hurt, right? That was kind of the question we were aiming to answer here. So I know that was a lot. So, anyone, team, jump in.
Yeah, I think how do we keep the pressure on, or how do we keep this moving? I think, and I hate to say this from the in the hospital side, but payers and government need to ensure that in addition to all of the incentive or penalty programs that they have, that there is a lens of equity into it. So again, I said this earlier, right now, there's a very long list of outcomes and quality measures we have to perform on. And but there aren't really any that ensure that there's equity to that, right? So I think that needs to happen, and Blue Cross is very much leading the way with a lot of this, which is great. I think as far as technology, this is where we got to be really careful. I think the everything that's going on in this conversation is there's no silver bullet here. Digital health and fancy tools, better apps and all that actually could create even more of a divide, right? You see all these things about what's being successful in communities of underserved people with COVID vaccines. It's boots on the ground. It's people going to the churches, the people going to barbecues. You can't replace that with technology, and that takes a lot of time to build that trust up. So I think it's a real caution to organizations like mine to say a vendor is going to sell you a really fancy AI widget, but while that might get you an improvement overall in your population, it actually could create more inequity because you're not addressing the real, everything we've been talking about, the trust issues, right? It's too easy. We got to do the hard work to really build relationships. That being said, obviously, I think technology is, a necessary but not sufficient kind of part to all of this. But if we don't address those underlying foundational things, it's going to be, you know, it's not going to solve these problems.
I completely agree, Chad. Technology, the data is not alone. You know, it's not enough alone. I think of something that I was really excited about as public health practitioner, which is the implementation of social determinants of health screenings in like healthcare provider settings, which is for, I'm not sure if people are familiar with those, but it's like a small checklist. It could be long of doctors or providers asking patients about housing, transportation, and food. And so it's like, yes, that is a win, and connecting people to those resources. But as an institution, if these healthcare providers are also not hiring locally, if they're not choosing their vendors intentionally, then I almost feel like, okay, you're addressing something at an individual level, but what are we doing at an institutional level? And I think that before we jump probably into questions, I think that's the piece that at least that I want to say directly, that we need to look at institutional change, not at organizational, at an individual level, but what are we doing as institutions? And I'll also like name what we know, that, you know, the CDC has said that racism is the biggest public health, one of the biggest public health threats right now. And so we need to look at how our systems are set up to exclude, how to exclude individuals and be disproportionately affected, you know, economically insecure before, and that's all related to their health. So not before health, but really look at health, not just in a four-wall setting where someone is getting care, but how are we supporting families and communities?
And before I pivot to questions, because they're coming in and I'm really excited, KRISHNA, anything to add to what Chad and Yelita have said?
I was trying to should we go to questions? Should I jump in? I think the agreed on the comments there. I think all I would say is technology and data are just tools, right? They're like a pen, not a piece of paper. And so it's like what you do with it is what matters. And I think how do we implement in a competent way certainly matters. And you could say the same about everything, every piece of technology we've ever implemented. And you could say that, you know, physicians don't like EHRs and they think it's not, you know, sort of implemented in a sort of a workflow competent way. And so there's always that learning with any new piece of anything we introduce in the world. And I think you add the lens of equity, I think it complicates the matter more. I think overall, you know, more data is good. It at least shines a light on opportunities. And then how do we change those sort of opportunities into action, I think is one that, whether it's institutions or individuals or organizations like ours, we all need to sort of fight the good fight. And these things were built up bit by bit, and we have to sort of dismantle them bit by bit. I don't think we're going to have one big sweeping something that's going to topple any of these inequities. It's going to have to, we all have to just stay consistent, stay focused. I think the telemedicine is certainly, as I shared, is a bright spot. I appreciate that. We actually started incentivizing for the social determinants, vitals, the data you spoke about. Again, I think that'll start to, you know, we want more people to collect, and by collecting, it naturally opens up the conversations with patients and caregivers. And so I think we're excited about that. And I think as we bake that into workflows and reporting, I think it'll be another new dimension for us to work through as well. So many, many miles to go, but obviously optimistic about the role of technology, about data. I think it certainly helps us more than hurts us from my perspective, but more miles to go for sure.
Thank you. All right, I'm pivoting to questions. I'm super excited. Everyone's engaged and fired up. So I'm going to do first in time, first in right. So first question that came in was, through their current data, do they see improvement on health equity?
Yeah, I mean, I can answer that. So just as far as where we're at in our journey with this, our new reporting year starts in October, but we'll come out with the first reports in November. And this last year, we've spent the time identifying what specific measures we're going to hold ourselves accountable to, which in and of itself is hard. I mean, you think about the 500 things we measure, where do we want to focus? So we identified 3 measures that are now going to be on our corporate scorecard that we're going to hold ourselves accountable to. So talk to me in a few more months, right? And we're going to begin our improvement activities literally starting in a few days. So the goal would be and we've set targets too. So it's really explicit goals we've set for ourselves that we are to achieve by the end of this reporting year, which would be the end of September of 22.
Got it. Anyone else before I go to the next question?
Yeah, I mean, I'd say early in the journey, and I think Raj just said that it depends on what you're measuring. I think we are certainly seeing more engagement and participation in our sort of community centers. I think it's showing up in the long tail opportunities of screenings and rate reduction. Those tend to be multifactorial, multi-stakeholder journey there. We certainly do see disparities, although we're not certainly closing the gaps, unfortunately, yet, but we're very, very committed, and we're certainly putting an effort and energy to do so. So I'm optimistic, but more to come on that.
Next question. With healthcare accelerating their use of technology to improve patient experience and to make it easier for patients and potential patients to schedule appointments, refill prescriptions, get questions answered, etc., what are you doing to ensure that this isn't creating greater inequities for certain socioeconomic groups and demographics? For example, how are you ensuring that non-digitally engaged groups are still able to get reminders about appointments, get preemptive information about how to improve their overall health, etc., so that they don't get left behind?
That's such a great question, and something that I think about a lot working with older adults. So yeah, a lot of the technology that we have improves the communication, the convenience of accessing healthcare or getting our test results. But there's two questions. Like, one is that for those of us who already have access to these healthcare systems and who can use it. And so for me, something that I saw during the really early vaccine rollout, when we were only vaccinating 65 and older, was this reliance, this shift on moving things to technology, because that's to tech and like online platforms, because that's what we had. But a lot of people were left behind. I think a lot about the older adults that I work with, and the three things that you mentioned: access to broadband, is it there? Sometimes access to devices. Sometimes are they technologically skilled? Some are interested, but again, like, these are really big issues for individuals who are facing other inequalities in terms of housing, transportation, and things like that. So my question would be that for some of us, it's making our lives better, but for a lot of us, it is not.
Yeah, and just to tack on what Yadira is saying, that's why measurement is so critical, right? We need to make sure we're measuring the effect these interventions or these strategies are on these populations, right? So if we're rolling out a new digital platform, let's not just assume it's having an impact. We actually need to see, is it making an impact with regards to the funds of equity in our more vulnerable versus not populations, and then correcting if it isn't.
Next question. How can providers and payers help streamline the awareness and engagement process? Does that look like a large marketing campaign or smaller scale, including basic telehealth info and intake forms / reminders?
I could take it, and Chad, obviously love to get your take on it too. I think as with most of these things, these tend to be multimodal, right? So there's not a either or, there is a and the conversation here, right? So I'll give you a pandemic example. So we had a bunch of our screenings, as was consistent with our provider communities were down, right, by like 20, 30 point reductions in sort of preventive care screenings, which obviously you all, see the consequences of some of those. We're talking about like mammograms and immunizations, so not good at all. And so we had to do both. We had this sort of wellness can't wait campaign that we sort of did as a broader marketing effort there. We then targeted with sort of selective sort of speakers and stakeholders that will resonate to certain sort of communities. We shipped our care vans, which is sort of a mobile thing that we've had for 30 years, across certain zip codes where we were seeing sort of these screening dips. We used our Blue Door Neighborhood Center, and we used a bunch of brute force phone calls to reach our members and say hey, we see you haven't done this, and tell us more why, and what can we do to help you bridge the gap and barriers. We also sent out mailers and we sent out email reminders. And so it's a little bit of a, I wish there was one answer for any problem we have in healthcare, but the answer is there isn't one answer. So you do have to have a multimodal approach, some more effective than others, and obviously some resonate depending on your audience differently. We still send snail mail, in 2021. We still actually accept paper claims in 2021, and that's because we have stakeholders that aren't ready for digitized electronic systems, and that's okay. I mean, the snail mail claims is like 1% of the million claims you get a day. That's okay, but we certainly want to accommodate people in places where they are and the journeys they're in. So some of this is going to be just a multimodal approach there. Chad, anything from your side and the provider side? How have you sort of approached this?
No, it's really well said. I mean, it's yes to all of those things. And the reality is we don't really know yet, right? So we need to small tests of change and again, not to be a broken record, but measure what makes an impact.
Okay, we have 2 minutes left. I'm going to try to tackle one last question here. The mistrust in the underserved communities is very hard to get past, coupled with the shame of admitting the need for help in something that you see is not related to your health, such as food insecurity or relationship safety. That is coupled with recognizing and acknowledging the disparity and trust issues as part of the problem. What ideas do you have for incentivizing populations of people to participate and engage? I'm getting ambitious here in the final moment.
I think I have to respond, like KRISHNA mentioned, like there is no one, I think, response to that. I think about, I think I will respond with more questions. If this is a healthcare provider, then what are you doing outside of the patient room to build trust? How are you visible in your community? How is the professional training of the providers and the staff in terms of interacting with these communities that have been there's documented mistrust, and rightly so, within the healthcare system. I think the other piece so I'll just leave it at that, because I think the two questions, the food insecurity and the relationship, I think it's follow through. So one of my big projects, I was working on a contact tracing program, and it was really interesting to hear. It was good to see that interviewers were asking about what needs someone needed, but I'm not sure about the follow through of those requests. And it was just like, there's this 1-800 hotline number, call if you need food or if you need rental assistance. And so I think that there's work to be done in terms of that follow through.
Thank you. Thank you. And we are at time. I want to thank our esteemed panelists in the audience for joining, providing some great questions. Thank you for the answers. If we didn't get to your question, we'll get to you by email, and we look forward to seeing you at one of our upcoming events. Remember that evaluation survey if you want CPE. Please visit our website for more information and any upcoming events. Have a great afternoon.
Thanks all. Bye.
Bye. Thanks so much. Bye, folks.